So now look at the left ventricle. Left ventricle has the most important part is, look at its apex, nothing in the apex. And we happen to see two papillary muscles. One is the lateral, I always say as lateral. And other is lateral. Why? Lateral is attached to lateral wall and the inferior papillary muscle on the inferior wall. Where RV does not have any papillary muscle, there is no apical tuberculation except sometimes a moderator band, and it's elliptical bullet shaped structure. On the contrary, RV is heavily tuberculated, it is moderator band in it. Then on top of that there is no papillary muscle in RV and it's a triangular structure. So look at this in total profile once you understand that. This is LV, this is RV, and majority of time the tricuspid valve will go along with this RA to RV through tricuspid valve, whereas LA goes with LV through mitral valve.
And the valve is septophilic also. This tricuspid valve is septophilic compared to the mitral valve which is septophobic. So this valve is attaching to the septum, whereas this valve is septophobic.
Away from the
septum.
Is that okay? Any questions at this point?
This is very beautiful view to find the apical displacement and the septophilic nature, and the tricuspid valve will always go with the RV. So if you identify this valve, this ventricle is always RV. This is the easiest method to pick up a ventricle.
It is coronary sinus.
Yeah, here is the coronary sinus we can see draining into the RA.
It's always part of left atrium, related to left atrium, open into right atrium.
So this coronary sinus.
Is that comfortable?
Can we see the right atrial appendix here?
Right
It
atrial
is most
appendix.
anterior structure, so it is anterior to aorta. So 5 chamber, subcostal, very comfortable we see either from subcostal in pediatric, parastern short axis view, a little modified because that is the most anterior structure in the heart, right atrial appendix. Most anterior structure. And this view was very posterior.
We go in subcostal and then see ventricle.
This patient has got a very good IVC SVC rather than right atrial appendage.
This might be thumb-like structure, yeah.
Yeah, this.
Could be.
And did you use SVC for the RA identification? SVC? What about SVC to identify RA? Any opinion from the audience about SVC?
Colors.
We are talking only about IVC. That means can SVC drain into LA?
No, no.
Even Bias is not talking about SVC then? He is talking only about IVC.
No, I am talking about SVC. I am locating SVC first.
But in any book, every book IVC is draining into RA, not SVC. Why? That means SVC can drain into
LA.
SVCs do drain into LA. So I have seen 3 cases till now which SVC was draining into LA, and we have done surgeries for those cases.
What I was trying to show was like sometimes it's not always like this is a bicaval view which we see in normal adult populations during transesophageal echo. Sometimes we do see in pediatric population looking at a bicaval.
Now this is right.
Yeah. Sana, any question by now? You are going to have a lot many questions, Sana. You are not going to be set ideal. So last comes to be identification of great vessels. So once you see this kind of a structure, that's how I say always is, if you happen to see a cup and saucer shape of a structures, this is always a atrioventricular ventricular arterial concordance. Aorta in the center, and the pulmonic artery wraps around aorta Here's a pulmonic artery arrow. This is aorta in the center. LA, RA, tricuspid valve, RV, RVOT, proximal and distal, tricuspid, pulmonic valve, right pulmonic artery, and left pulmonic artery. If you happen to see this kind of a structure, always think of a ventricular arterial concordance. And if you see two structures lying close to each other, like two rounded structures close to each other, always think of something else is happening. I'll not say always TGV, something more can be happening with these two structures. So that's how we number of time identify the situs, atrias, ventricle, then tricuspid and mitral valve, and finally the great vessels. And last, I always say, like Neeraj and Manish can correct me if they, pulmonary artery always bifurcates. Aorta has till date not bifurcated except for truncus when it's given rise to aorta and then bifurcated to pulmonary artery.
So in congenital there is always a variation.
Variation is always there.
Always there.
Is
So
it always necessary to have a two-rounded structure to make TGA?
Like one is like we just talking about identification of
Yeah.
blood vessels. So aorta. Identification of aorta is by it doesn't bifurcate and it goes into arch. Rarely when PA arises from aorta, one of the branch, not always truncus, one of the branch arises from PA, that is anomaly, either left pulmonary artery or right pulmonary artery. Okay, but you see a bifurcation, so you may confuse it that this is TJ, but it is not. So you need to again follow that particular vessel into which is going into arch. Okay, so aorta with one of the branch arising from ascending aorta, and main pulmonary artery is going into one lung only. Okay, so you have to have all possibility in your mind. This type of patient will be acyanotic. Okay, will be into CHF because one pulmonary artery is arising from aorta, so lots of flow is there into one lung. So CHF without cyanosis. So clinical is very important.
Yeah.
So
I have a question also. Sorry to interrupt.
Yeah.
We have to face many things like adult congenital.
Yes.
We are doing with the adult congenital. But we don't find typical two round structure side by side. But we have seen that one structure is bifurcated and another is not bifurcated. One is a single tube. And after all, whether if you don't find that two structures side by side, but we think that is a TGA.
with transposition means TJ means when we say
Transposition.
VA discordance.
Yeah.
Okay.
Yeah.
So VA discordance, great vessel relation can be any.
Yeah.
Commonness is D malpose. You can have anteroposterior, you can have L malpose, you can have side by side, you can have normally related.
Yes.
So you can have any relation. Okay. The point is you need to follow from which ventricle which channel is coming.
Yes.
Okay. Don't if it is not related normally, you have to think for the transposition of great vessel. Okay. That is one thing. But the most important part is need to follow inflow and outflow. That is most important. Follow the segments. Where they are related, that's why Anderson says, you just define the structures where it is. It is right anterior, it is left anterior, but it is atrioventricular concordance, ventricular discordance with this relation of great vessel. Okay, so
So we find difficulties for
Adults, no, in adults.
adults, like for an adult, if I think transposition of great vessel to survive into adult, obviously this is very rare until unless they have ESV, PS type of physiology.
there is some chance.
Yeah, there is some, and that is obviously there. So rare presentation in adult, but again you need to you are having suspicion means, and when doubt we go for higher imaging. Okay, so CT is easily available and should be done in adult patient to have a detailed information. CT should be done in this type of scenario, cyanotic heart disease, congenital, that group CT is needed. But when we are doing echo, because when we send a patient for CT angiography, radiologist asks our basic diagnosis. Okay, and even before relieving their final diagnosis, they sit with us and ask for the segmental analysis. Okay, so it is important for our coordination with the radiologist, but we need to follow our segment that I am seeing this, please, I need further information from you. So, segmental analysis is very important. ठीक है, जो दिख रहा है it is okay. We need to mention we have our limitation when windows are not good, but and that can be mentioned, that poor imaging, poor echo windows, I need further imaging to define
Chest
this
deformity
particular
is
area.
another drawback. Chest deformity.
Chest deformity, yes, very important.
Obesity,
Obesity,
yes.
adult patient, lots of issues. For us, it is very easy. In pediatric, very easy. But adult, it is difficult system thing for you to define congenital cardiac defect, because any segment can be abnormal. That is the problem with us.
So I would add, if it's adult cyanotic, you're talking about CT or MRI. If adult acyanotic, you're talking about TE. Most of the time, this should give answer. Okay, but yes, you have to have the basics clear. Like here again, I would add this window, long axis view. You see a lot of long axis. No, if this vessel is going straight, this is normal rate. This means this has to be aorta. Even if the P's are rising from this will not bifurcate so early. So even if, but what someone was saying, P is bifurcating means, yes, this is PA. But if his P is not bifurcating, it doesn't mean this is not a P. So then you go to the aorta, the other vessel. If this other vessel is not bifurcating, I know this is aorta. The orientation of this mitral valve, the aortic orientation is like normal. If the PA is arising from this will not go straight. The PA will come down. In long axis also. The PA will come down, it will take a different course, not the straight course. It will go like this. So, and second thing, in long axis also, you will not see two vessels together. You will see one vessel in one view. You have to tilt the probe to see other vessel normally. If you are seeing two vessels together, you are talking about, no, this patient is not having normal related great vessel. That means wave concordance is not there. That can be added. Similarly, shortest has shown, the P is bifurcating, this is normal related. If P is not bifurcating, then I am confused which structure is what. Sir. Anything else? Arch, we have shown the arch.
Okay, I will show that. Because arch is another important thing, is left-sided arch, right-sided arch. That's another important issue when we look at these kind of things. बेटा सीधा लेट जाओ, सीधा लेटो. थक गया साइमा? You must be wondering why we are spending so much time on these basics. Because this is what is important. Rest is all applications of all these basics, So I'm going to go to a suprasternal window now. बहुत मोटे सारे कपड़े पहन के आई है तुम आज. So what we look at a suprasternal window, and the most important part of a suprasternal window is to identify the arteries arising from suprasternal window. So I'll put on a colors and try to identify the first artery from a left hand side. First subclavian, Dr. Neeraj can show the subclavian. Then left common carotid, and then the innominator vein. Right? Look at the innominator where is arising. Almost to the right side of the screen. Correct? If this innominate arises from the left side of a screen, where the left common carotid is arising, then possibly you are dealing with right-sided aortic artery.
Here you can identify the population of aorta also.
Yeah.
You can identify the population here. Somewhere here it is the shelf and the turbulent structure, which we will discuss in the future classes.
And even PDA also number of times seen in this view.
Yes. If normal PDA come like this,
Yes.
vertical PDA can come like this. But yes, PDA should be seen. And the branches, pulmonary artery.
Correct.
RPA will be seen just behind the aorta. It's the right pulmonary artery.
And one more view before I switch over to my slides. थोड़ा सा ऊपर करने बेटा. This is what we now see is, if I do my cross section of this particular vessel, I go a little up. Look, this is what is ductal view. Is that right, Neeraj?
Yeah, approximately yes. We will go side.
Yeah, slightly higher because
The chain is covered tight करने वाली.
I know.
Close, tight, close.
थोड़ा सा ऊपर करें बेटा. हाँ. बस बेटा हो
Yeah,
गया.
you want to go high parasternal side.
Now I'm almost hyperextended. Now you can see this very clearly. This is aorta. What I do normally is I'll just go footprint looking towards left shoulder. And as soon as I'm moving a space up and left shoulder, my aorta is on left hand side, right side of a spleen, and here is a pulmonic artery. In adult population, what we are tuned to, if we tilt our transducers toward mediastinum, we get RVRA inflow view. Correct? If you tilt your transducer towards left shoulder, you get a ductal view. And this is pulmonic artery, which is bifurcating. You can see a pulmonic artery bifurcating over here. 1 and 2. And pulmonic vein can be seen right over there up to top. Or upper. Here.
The valve is
Yes, pulmonic valve over here. So this is where we can really look for a ductal ductus, and in pediatric population very easily you can look at these kind of structures. RVR inflow view, opposite of RVR inflow view is always remember a ductal view, just a space up. And this is aorta in cross section. You can see the aorta in cross section over here. Correct? Any questions now before I stop the live demonstration? Then show a couple of slides and then break.
Will you show the SBC?
SVC,
Then you have to go subcostal
I have to go to subcostal or suprasternal.
Suprastar.
Suprasternal.
Suprasternal short axis
Short
is very
axis,
important.
yeah. लीजिए थोड़ा सा हेल्प कर दो
ये ले लीजिए।
नहीं How do I identify that the aorta would be red in color and SVC would be blue in color simultaneously?
Around 3 o'clock, sir.
So this is short axis view, cursor towards left shoulder, and this descending channel. This is superior vena cava, and I put color. This is blue. This is right-sided SVC, and I have to look for innominate also. This is my innominate vein. If there is left SVC will descend here. So here the left SVC will descend. This one. This is shadow only. Sometimes we get confused.
What is the cursor position here?
Same
3 o'clock?
towards left shoulder
Left shoulder? Oh, no.
and arch branching. First short axis is very important for arch branching also. I have to see bifurcation of the first arch, which is innominate. Okay, so first branch, यहाँ पे you will see a V formation. So carotid and left and right subclavian artery, then your left carotid and then left subclavian artery. So all branches you need to demonstrate in patients.
Why do you want the bifurcation on the right side, man?
Yeah, bifurcation on right side. One is bifurcation and second is split side.
So sometimes in apical fourth chamber view can show a flow of SVC also. Apical fourth chamber
Yes.
view.
Apical fourth chamber will get IVC. Slightly
I-
enter when you go, it's SVC. Okay, so because IVC is posterior inferior, SVC is posterior superior, so that way anteroposteriorly these things are related. Okay, so typical fourth chamber you will get SVC and right lower pulmonary vein. Slightly anteriorly you open aorta, you will get SVC and the right upper pulmonary vein, right inferior with inferior vena cava.
Right.
Okay, but to see the length, you
Yeah.
need to have either suprasternal short axis view or bicaval view.
My view.
Okay, because length is important for us. In pediatric population, we can also see azygous arch joining SVC, so lot of information you get in pediatric patient. Sidedness of arch is important for us from congenital point of view. That is one thing. One is whether it is left-sided or right-sided. So when it is left-sided, and that is defined which side it is descending. Okay, so arch ascending part will be same in all patients, whether it is left-sided, right-sided, double aortic arch. So it ascends and it descends on the left bronchus. Okay, when it descends on right, it is right-sided aortic arch. And in short axis view, my first vessel, innominate, was to right and it was divided. Okay, so innominate we all know it is to right and it divides. in right aortic arch, it will to the left and divides. Okay, so it will be inverted. Double aortic arch also you can define by echocardiography in pediatric population because we were talking aorta doesn't divide, but it divides in that situation. It form two channels and unite and descend posteriorly. That is a type of vascular ring. Okay, so in short axis view you will see two circles. In suprasternal short axis view at different level you will see two circles. We have, I mean, there are many publications online, many things.
What is the look about the interrupted aortic arch? Look, echo look.
Interrupted, like we were saying, showing whole length of aorta in suprasternal view. In interrupted aortic arch, it will be interrupted. Okay, and we'll see PTA is feeding that way. Okay, so in rest of the presentation on aortic arch, we'll show those images, and I have lot of collection in mind. So whatever image you want to see, we have in our archive. So, but this is a patent aortic arch. If it is interrupted, the many sign of interrupted aortic arch, when you look at 4-chamber, many things are there. We'll discuss about that, but you will not see this continuity.
Madam,
So directly,
in right aortic arch, the index marker should be rotated counterclockwise to get
Yes.
the clear view.
yes. So I have to, like we were to get this long axis view, it was towards left. Here you need to turn your transducer towards right to open this length of the aorta. And in usual suprasternal view, you won't get this view with right aortic arch.
But when we rotate the counterclockwise, view is same.
Yes.
View is
Yes.
same.
So you only know that you have rotated the cursor.
Yes, yes.
Okay. So I don't know. If I review your images, I can't make out that it is right aortic arch. If you acquire short axis view, okay, then I can know because first branch is going towards left. Okay, so acquiring both views is important because someone else may review your images. But by long axis view, I can't.
For this, we should take short axis view.
Short axis view to demonstrate first branch is going towards left in right aortic arch, towards right in left aortic arch. Okay.
So I will simplify this long axis. If the cursor is like this for left arch, if you go like this, to right arch. Very simple way, but only thing you can't demonstrate it. So if you want to demonstrate, otherwise this is very easy for you to diagnose. So what I am saying, when I have asked like this, left arch,